Okay. So this is the first case. The screen is visible, right?
Yes, but it's slightly blur on the edges. I don't know why.
Yes, I don't know why as well. It's okay. Concentrate on the central part. So this is a 62-year-old patient with high white cell count, and the blood film shows lymphocytosis. This is the power 10 of microscope.
Mhm.
Just an overview at power 10. Okay. Now I will move to power 50. Oil lens. Uh, let's see some more.
Patient has spleen, or just the lymph nodes.
Just the lymph nodes. And I will make it to 100 finally.
Mm, there is lymphocytosis with small, mediums to medium size lymphocytes with abundant cytoplasm. However, cytoplasm is showing projections. Chromatin is quite clumped. Can see nuclear contour is regular. Nucleolus is present in few. But you just mentioned there is no spleen.
Hmm.
Any rash or any autoimmune disease or anything?
No.
No, just lymph nodes and this.
Yeah.
RBC morphology is unremarkable. However, I saw few elliptocytes. There is cytoplasmic projection, hair-like projections with prominent nucleoli.
What is this?
This is monocyte.
Okay.
I think normal lymphocyte.
Oh,
Platelet seems to be normal with normal morphology. Neutrophils are present. Hmm. Mm. There is no clefts. There is no marked pleomorphism in the cells, but there are hairy projections.
okay. So now I would ask you to report the blood film.
Okay, I will repeat whatever I said. There's lymphocytosis, which are small to medium size with abundant cytoplasm in few, and nuclear chromatin is quite clumped. Nuclear contour is regular. There is few cells still show, I don't know, it's an artifact or hairy cell projections, and RBC morphology is unremarkable. And leptocytes, however, few leptocytes were seen. Platelet count seems to be normal. I did not see any spherocytes.
Mhm.
So, in conclusion, it's lymphoproliferative disorder. So, I would like to go for immunophenotyping or flow cytometry. Hmm.
Okay. So
Because you, mm,
there is lymphocytosis. Is it pleomorphic or
no,
not?
no.
You mentioned there is a possibility of lymphoproliferative disease,
Hmm.
and you requested for flow cytometry as well.
Yes.
All right. So
Or patient has fever because this
patient
one
has
is showing
patient
projection, scalping.
patient has no fever.
Mm-hmm.
He is 62-year-old and
With lymphadenopathy, generalized lymphadenopathy, no splenomegaly.
lymphadenopathy and high white cell count, and the white cell
Hmm.
count shows lymphocytosis.
Hmm.
White cell count is 24.
Okay.
So you requested for flow cytometry. Flow cytometry shows CD 2 negative, 3 negative, 4 negative, 19 positive, and 20 positive. What else you want to know?
I want to know about CD5.
CD5 is positive,
Okay. Then I want to know about CD23.
23 is negative,
Then I want to know about SOX11 or
SOX11
if
is positive. We did
and
that on a lymph node
Trifine.
biopsy.
Okay. And for what about cyclin D1?
Cyclin D1 on immunohistochemistry also
Chemistry
is positive.
is positive. So this is mental cell. But the morphology maybe looks more like um, with abundant cytoplasm. I did not see pleomorphism, or I could not appreciate pleomorphism too much. But this flow cytometry goes with mental cell.
Yeah. And the morphology goes with
With I think monocytoid type or marginal zone type of mental cell because there is abundant cytoplasm.
hmm mantle cell lymphoma patients usually have abundant cytoplasm in their lymphocytes,
Yes, but
but they
again
are
they
not
show
marginal zone,
pleomorphism.
like because the cytoplasm is clear, it's not basophilic.
Hmm. No, they have one category of mental cell lymphoma, which has abundant and monocyte type cells of marginal zone cell lymphoma, resembling them.
Yes, now there are 4 or 5
Mm.
categories of
Yeah,
mantle cell
categories,
lymphoma
yes.
now.
Because small cell, it resembles CLL. This is not small cell mental cell. And there's no pleomorphism. It is not blastoid type. So maybe the other category.
Yes, mantle cell lymphoma is very difficult to diagnose on blood scan
Morphology
only.
only. Mm.
You always need flow cytometry for that.
Can you appreciate nucleolus in few?
In few of them there are nucleoli, but not all of them.
Yes, not all of them, but few of them had it.
I think this one has.
See, this one has, and it has abundant, slightly basophilic cytoplasm.
Okay. What is the staging modality? How would you stage this patient? Would you like to do a CT scan or a PET scan?
Both are recommended now, but preferable is PET scan.
PET scan is recommended now
Yeah,
for the mental cell
mental
lymphoma.
cell staging.
Okay. And translocation involved is
11, 14.
11, 14. Right. So if this patient is, for example, let's say um, stage 3 and stage 4,
Advanced stage.
advanced stage disease, but
Mm-hmm.
uh, he has no B symptoms, there is no symptomatic like symptoms or organomegaly, or there are no cytopenias. What treatment options do you have?
There are no cytopenias, but patient is still has advanced stage on PET CT.
Hmm. Indolent disease, asymptomatic disease, but he has stage 4 or stage 3.
Indolent disease, you just wait and watch.
Okay, fine. But if this patient has persistent B symptoms and you want to treat this patient, then
Then for stage 4, I will check patient eligibility if is uh, transplant eligible, autologous stem cell transplant eligible or not eligible. And if transplant eligible, uh, then we give cytarabine-based therapy, alternating with R-CHOP.
mhm,
And once the patient is in complete remission or partial remission, we proceed with autologous transplant and then maintenance with rituximab for 3 years. And
yes.
if patient
So
is not transplanted, yeah,
Nordic
Nordic
protocol
protocol.
in short.
Yeah. And now,
Because in morphology case you would not have this much time to write everything. You can just write
Nordic
um,
protocol.
Nordic protocol.
Yes. And now I think Young's trial shows role of ibrutinib
Yes.
as well with or without transplant.
Which trial you mentioned?
Um, Young's trial, right? Triangle trial, sorry.
Triangle trial.
Triangle
It's
trial.
triangle trial. Yes.
Yeah. Young's
It has
trial is
been.
for autologous stem cell transplant
It is approved, but we have not yet started treating the patient with ibrutinib because of the funding
based
issue.
therapy. Okay.
So for a fit patient, you have Nordic protocol or Lima protocol, in which you use uh, RDAP, and you transplant the patient in CR, then
Yes.
rituximab maintenance. And what options do you have if the patient is not fit for transplant?
If the patient is not fit for transplant, then you have option of BR, RBAC, and with bortezomib, VR cap. But the one which is recommended is RBAC.
Okay. So if this patient relapse
Mm-hmm.
after 2 years, uh, let's say um, you have given him a Nordic protocol, would you
Mm-hmm.
offer CAR T after the relapse?
Then I will risk stratify the patient,
Mhm.
and I don't remember exactly the risk stratification, but it depends on Chi 67 more than 30, uh, POD 24, then blastoid morphology, then presence of TP53. We will offer the patient first abrutinib, and
Mhm.
if the patient remains in remission with abrutinib, disease becomes stable, we will continue abrutinib. If there is no remission, then we'll discuss the patient initially with CAR T specialist,
MDT.
MDT and CAR T specialist. And if the patient does not respond to the treatment of abrutinib, then we will refer the patient for CAR T therapy.
Mhm. So CAR T is third line in mantle cell lymphoma,
Second is
and
abrutinib.
yeah, and the patient must have BTK ibrutinib. Without exposure to ibrutinib, you cannot uh, give CAR T to mantle cell lymphoma patient in UK. It is not funded.
Mm-hmm.
Mm. Right. So the second case is uh, a patient who just arrived from Africa to UK, and the GP has found eosinophilia in the patient. This is powerful. So what comes to your mind if there is eosinophilia in a patient?
So with the eosinophilia, we can think of parasitic infection, especially with the recent travel history.
Mhm. And what else?
And drugs and allergy.
Mhm. So in morphology paper, they may not ask you about the secondary cause of eosinophilia, but if it is a viva, like not this exam, the one before us, there was eosinophilia in the malignant viva. They ask the people what are the secondary causes of eosinophilia. So Himbias has given a big table of eosinophilia. So better to remember five or six from them. So if there is eosinophilia, always start from power 4. There may be a worm in the blood film. If there is no worm in the power 4, then it will be eosinophilia associated with uh, malignant neoplasm or chronic eosinophilic leukemia. This is power 4, and we can see there is a worm inside. This is power 10. And in UK, lower is quite a lot, and we have worm blood film from parasite blood film from Nikwas after every 3 months. And if it is a worm, most of them are the uh, lower. I will check another one. There are quite a lot in this Nicholas film, but in exam, uh, you have to struggle to find the worm. Most of our people miss the worm in this exam. So, what do you think about this worm? Is it a sheet or non-sheet?
Sheath.
Yes, it is a sheet. This is the sheet. This is a sheet worm, and this is the head end, and this is the tail end. Make it big, 100 power. So, have you made any mnemonic to remember the names of the worm?
I think you have to revise it. Lower, I remember that it extends lower down to the tail.
To the tail, yes.
Yeah. What else was there? I've forgotten your mnemonic.
Then there was a Brugaya Malai, B for Brugaya and B for binuclei. They have two nuclei at the tip of the tail. And another one was Vemti for Wuchereria bancrofti. Uh, Bancrofti is empty or Vemti. Uh, their tail does not contain any nuclei. The tail portion is empty of nuclei, while the lower extend to the lower end of the tail. So I remember it like this in the exam. For the exam.
Do we have to mention lower? Is it lower, or just like it's no need to mention the species, I think.
If you mention that, you will get full marks. First of all,
Mm-hmm.
they want to know whether it is a sheet or not sheet.
Okay.
But it is easy to figure out because, like, this worm has a big sheet
Sheet.
hanging
Oh.
around here, so it's easy. And then this end, if you can tell them whether uh, this is lower or Brugaya Malai or
Bancroft.
Bancrofti, then you will get full marks, 9 out of 10.
Mm-hmm.
Uh, this is a sheath area. The tail ends here, and all these nuclei they are extending to the tail end.
Mm.
If ever I find any um Leucorrhea or Brugaya Malai blood film from Nicholas, then I will bring it as well.
Mm-hmm.
But most of them, uh, I have seen the record of the Nicholas for the last 5 years. They mostly send either trypanosoma or lower or malaria.
Did you get lower this time?
This time it was lower.
Mhm.
Mm. So they will ask, report the blood film. So what would you say? How to formulate a report for the exam? Yeah, say something.
Depending upon the morphology of RBCs, there could be anemia or it could be unremarkable. TLC
Usually
would be.
eosinophilia.
Hmm. So
Yeah, the
start with the xenophilia.
usually they have eosinophilia. So the blood film contains eosinophilia and sheet worms.
So do we
So
have to mention the morphology of these worms as well?
yes, you have to say that the blood film contains eosinophilia and sheet worms. The worm has nuclei extended to the tail end. Most likely, it resembles to lower, which need to be confirmed by sending the blood sample to the reference lab.
Mhm.
Yeah. So then they usually ask the next question about uh, investigations. Investigation, we always say send a sample to the reference lab to confirm the diagnosis. And third question is what are the treatment options? So lower. Um, we usually give them, I think, duck or mebendazole, if I'm not wrong. Dacarbazine and um, mebendazole. Don't try tapeworm in the exam. One of the candidate in the course mentioned tapeworm. Mm, So the next one is a 36-year-old female with uh, headache and agitation. So this is the power 10. Let's go to the power 50. One. Do you have Asma or Sana on the line?
Yeah. Yeah, Dr. Amir, I'm online right now.
Yeah. I think
Yeah.
either you or Asma asked for parasite film.
Yeah.
Are you the one living in Halifax?
Yes, sir. I'm in
Uh,
Halifax.
I'm not, sir. I'm
Mm.
just
Okay. Dr. Amir.
mm.
Uh,
You can comment on this blood film.
okay.
So this patient is from uh, Northern Africa and he has headache and agitation.
Mm.
This is the blood form for you.
So, in this film, uh, there is the some relay formation on that film, mm, on the RBCs. Mm,
Mm-hmm.
the relay formation and the the prominent platelet count. The platelet count is unremarkable. It's and but uh, the size is like platelet count size is increased. uh, and
What is this?
there's some worm, looks like some. Uh, is there any traveling history in this patient?
Yes, this patient arrived from Northern Africa
Okay,
yesterday.
so mm, is the malarial parasites and
Why they are curled up? Show us some straight one.
Okay, then I have to search for that.
Mm, yes, because this is curled up, so it gives impression of yeah. These are all curled up.
mm,
The tail is hugging the face. Ah, this one.
here this one is the
Still big. Yes.
it's a yeah it's look like a trypanosoma
Mm-hmm.
trypanosomiasis. So it's a nucleus is in the body of the um, worm. And should I describe in more detail?
No, they do not expect much description from you. So if you have identified that there is trypanosoma there, that is
So
fine.
and
But
and there's no need to mention that where's the nucleus and the pointed head and the pointed tail.
no, but you should know from the geographical distribution whether it is trypanosoma cruzi or brucei, because one type of trypanosoma exists in South America, which causes Chagas disease, and another type of trypanosoma exists in Africa, which causes African sleeping sickness.
Okay.
This sleeping sickness has two
So
stages.
this is okay.
This one on
Is
morphology
the
is cruisy, right?
Brucey is in the
No, I'm talking about
no
morphology only. This one is
morphol.
cruisy
Why it is Brucey?
because
because
I just recently received uh, PT proficiency testing, and then they defined that if you have very prominent kinetoplast and small size, that is cruisy. If your kinetoplast is very small, smaller than this, and larger in the size, that is brucey.
but he said that
Hmm.
the patient is from African like so and we have to memorize geographically. So cruise is more common towards the North American.
Cruzy
But
is
this
usually in the
Chagas,
like C for Cruzy, C for Chagas disease. which
Hmm.
is in South
Mm,
America.
American, South American.
This
This
this is
person,
Nika's slide. What was their answer? Cruzy or Brucey?
Brucey.
Very
Mm.
strange.
More better.
Hamid,
Mm.
would you move the slide towards those abnormally curled up parasites so that in case
Curled
sometime
parasites.
the initially the you
Okay.
are showing initially, yeah,
This film has a lot of trypanosoma.
yeah.
This is a bit curved. Uh, but in the exam, you have to struggle. Remember that. Because in
Mm.
our exam, our blood film has only one parasite, one lower, and we have to search for that for 2 minutes.
This one is the curled one. Mm.
A bit curved.
No,
Uh,
no, you
fine.
can take this. Or
This is not that much curved. These two. This is a bit curved as well.
Dr. Mara, what difference you have told that in Brucey the kinetoplast is small in size?
The parasite in Cruzi is smaller than the Brucey, the whole size of the parasite, and the kinetoplast, which is present interiorly, is smaller. It's like a dot. And Cruzi has very prominent kinetoplast.
This parasite it has a very prominent kinetoplast.
That's why I thought, and the size, because recently I received from CAP, and it was the Brucey was bigger with very dot type of kinetoplast. This I reported it as Cruzy, this one. And their answer was also Cruzy.
Okay, I will move the slide. So this is another patient with abdominal discomfort, went to GP due to abdominal pain, and he took some blood from the patient and sent it to our lab. The BMS called you because he saw some abnormal cell in the blood film. This is power 10. Go to power 50. So this is the first cell.
What is the age of the patient?
Age is 48.
Okay.
They are lymphocytes, something else.
Can you go on higher power? Because
Yeah.
Some cells also were giving impression of eccentric nucleus and
are they hairy cell?
Maybe because the cytoplasmic projection is all around
Yeah, it's a cytoplasm is quite like
circumference.
adequate and a-granular light blue. Can you show some more?
Yes, I'll go toward thick side because these cells are mostly on thicker side, I think.
this one looks like kidney-shaped nuclei and nucleus and abundant cytoplasm, more like hairy.
Another.
Is there any possibility that it could be TPLL? I'm not sure, but
TPLL.
these sorry, I'm not sure. I'm just
Uh,
because
TPLL has very high white cell count,
okay,
and they have basophilic cytoplasm, mature
okay,
nucleus, and prominent projections, bigger than these projections.
okay.
See if I can find some more.
What is WBC count? This looks like typical. What is a WBC count?
3.
Is there any spleen in the patient? Any splenomegaly?
Yes, he has 22
This
centimeter
is
spleen.
very typical of hairy cell,
Mm,
classical.
mm.
So now the question is, report the blood film. How would you report the blood film?
Oh, basically, it shows lymphocytes. There is prominent lymphocytosis, which are small to medium size with abundant basophilic cytoplasm, showing circumferential cytoplasmic projection agranular. Nucleus chromatin is slightly clumped, and there is no nucleolus seen. And few cells has had a kidney-shaped nucleus. RBC morphology seems to be unremarkable, and platelet count seems to be slightly decreased. So, in presence of splenomegaly and low cell count, presence of cells with circumferential hairy projection, there is suspicion of hairy cell leukemia, and I will confirm my diagnosis by flow cytometry and BRAF mutation. Or on immunohistochemistry, I can confirm by TRAP positivity and BRAF proteins.
PrEP is not done here. And
It's not
remember,
done.
this blood film was from GP. You
Okay.
have to address something to the GP as well. You mentioned that this patient has abnormal white cells with hairy projection. Did you think that can be because of the hairy cell
Suggested.
leukemia?
Yeah.
You need to confirm that on flow cytometry and invasive
Bone marrow.
investigations like
Yeah.
bone marrow
Further.
biopsy.
Mm.
Please
Refer the
refer
patient
the patient
to
to the
hematology
hematology clinic urgently to
urgently.
start uh,
For the
investigation.
further investigation and treatment.
Then they may ask you what is the typical what flow you expect in this condition.
Okay, since it is a classical hairy cell leukemia, I would expect all B cell markers CD20, 22, 19 with the positive CD25, 111C, 123, 103. Cyclin D1 can be positive, but not bright expression, and CD200 can be positive.
And then the next question can be that this patient has symptomatic splenomegaly, which is affecting his quality of life.
Mhm.
What are your management options for this?
So if it's symptomatic splenomegaly, if the patient has no symptoms, we can wait and watch in this case. But in this case, the patient has symptomatic splenomegaly, so we will give
So in Viva, if I'm your examiner and I ask you that this patient has symptomatic splenomegaly, what is your
Mhm.
management option? Do not say that if this patient had no symptoms, then I would not give any treatment
Okay, then
because
we can
I
give.
have I have already told you that this is patient has symptomatic splenomegaly. So we were told that this thing annoy the examiner uh, to not to give statement which are not relevant to the scenario. Examiner have already told you that this patient is symptomatic. To start from symptomatic.
Okay, so in this case, I would go for purine analogs. Cladribine is a drug of a choice, with
Mhm.
or without rituximab. It depends upon the local guidelines or local treatment protocol. Pentostatin is another. That's it. It's enough.
With irradiated blood if required.
Yeah, irradiated blood if
This is
required.
important. And
Mm.
prophylaxis along with the chemotherapy.
Along, yes, chemotherapy.
So the next question can be, how would you monitor the the treatment response?
Okay, so the treatment response is measured after 6 months of therapy, and mainly depends upon the clinical symptoms, size of a spleen, um, lymphocyte count, your platelet count, I'm not sure about platelet count, and bone marrow involvement.
It is
Right.
by
bone marrow involvement.
By
repeating the bone
CD20.
marrow biopsy,
Yeah.
repeating the bone marrow
Bone
biopsy
marrow
after
biopsy and
4 months.
4
4
months or
to
6
6 months.
months?
4 to 6
Usually
months
after
is
4 months.
normally
Okay.
4 to 6 months. Okay.
So if this patient relapses, um, let's say after a year, do you have any options for this patient?
Then we can go for other purine analog, pentostatin, with rituximab. Or if initially he had good response, we can again try cladribine. But since the relapse, he relapsed within a year, so it's better to switch to another purine analog.
Always mention if there is a trial open in
Yes,
my
trial
hospital,
and restaging.
It's
I will offer
MD
MDT discussion, trial,
RAF inhibitors,
is
morphine.
and
draft.
mexatumomab.
Yeah, and
Moxetumomab
mexatumomab.
is not used in trials now because of the
VUD?
problem of capillary leak syndrome.
Okay.
Okay.
Patient drop blood pressure significantly.
Mhm.
So still, it's not nice proved in anti-CD22.
No, it's not yet approved. The same complication we are seeing with um anti-CD123 for
BP,
BPCDN,
yeah, BPCD. Yes.
tacrozofus.
So this the same side effect with that, with the capillary leak syndrome you are saying.
Yes, so the
Okay.
patient on tacrozofus for BPCDN, they
Mm.
dropped their albumin and blood pressure quite significantly. We have to monitor their albumin, we have to give them albumin, and we have to monitor their blood pressure as well. So this is the last case. This is a 33-year-old patient referred to hematology because of a big mass in the left inguinal area, and the CT scan shows that this is a lymphoid mass, and he has stage 4 this is a lymphoid mass. There is no other lymphadenopathy, but this is the only big mass in his left inguinal area. The full blood count shows high white cell count, and the blood film is in front of you. Patient has significant constitutional symptoms. This is power 10, just an overview of the film. Power 50. Put some more. Yes, Shaheen.
Mm, um,
Mm. You can comment on them, on these cells.
yeah. Blood film shows increased white cell count, and these cells are medium size with the basophilic cytoplasm containing vacuolations. Yeah, these are the
Yes, a very basophilic cytoplasm, right?
basophilic cytoplasm with vacuolations. Red cells are showing normocytic anisocytosis, bit anisocytosis, and they are slightly hypochromic. Platelet looks reduced, but I can see neutrophil as well. And there are nucleated RBCs also present, I guess. Yes, nucleated
Mm-hmm.
RBCs also seen.
So, what is your impression?
Um, I think with abdominal mass and these type of cells, I would think of Burkitt lymphoma.
Mm-hmm. So, how would you like report for the exam purpose?
Yeah, the slide shows increased number of abnormal lymphoid cells, and these cells are medium size with the basophilic cytoplasm and vacuolations. Nucleus is round and open chromatin, while the red cells are like bit hypochromic, otherwise and platelet reduce. I
They're
can
very
see,
bizarre, Shine.
yeah,
They're very bizarre looking. And this is
yes,
This,
apoptosis or this is
there's
yeah.
multinuclear?
There are some cells which are
Yeah,
dying.
yeah.
Sort of, yeah.
a lot of mitotic activity is going on
Yeah.
Mitotic activity,
Mm.
yes.
because
This is high grade.
Because it's a high grade tumor, so
Yes,
most
Yeah.
of the mitotic
mm,
activity is there.
But it's mitotic activity in peripheral blood smear to this extent I've never seen.
yes.
Uh,
It's unlikely to find these sort of these disintegrating cells and the
mhm.
mitotic cells in the peripheral blood.
this is original blood film
Hmm.
location, not
He
anequous.
survived?
No,
I'm sure.
no. So, the most likely a high-grade lymphoma, likely Burkitt lymphoma.
Mm.
The patient need emergent hematology involvement in this patient um, and initiation of the treatment. What flow markers do you expect in this condition?
But flow markers, it is BCL2 negative, BCL6 positive, and B cell marker,
You are telling me
CD10
immuno.
positive,
You're
and
telling me
5 negative.
immunohistochemistry. I'm asking for flow markers only.
Flow markers, 5 negative, 10 positive, and 20 as well positive.
Yes, 19 positive, 20
But
positive,
Nine-
22.
19, yeah.
43 is also, I don't know, I remember always the 43 is positive in Burkitt.
This 81 is usually positive in Burkitt. I think it is a marker of proliferation,
Yes, 81. Yes, yes.
and 38 as well is a marker of proliferation, along with plasma cell leukemia. It is
I think
positive in.
I-67, but this is on immunohistochemistry, but it's very
Yeah,
high, higher
57
than
is
100.
on, more than
Yeah.
99.
Yeah,
Yes.
and the translocations
Hmm.
What
814,
drug?
82, and 822.
Okay. So how would you manage? For
It's
example,
a we have
you have been given
major.
an open question. How would you manage this?
First is the TLS prophylaxis and monitoring for the electrolytes, hydration, and then planning for the chemotherapy. Chemotherapy is R-Codex, M-IVAC, and
Gem,
but first
gem,
it's the profile TLS electrolyte monitoring, TLS prophylaxis, uh, and hydration. In TLS monitoring of electrolyte, IV fluids, 3 liter, and IO charting, IV
Yes.
fluids.
So such questions can come in long cases as well. Like we have a question of plasma cell dyscrasia in the long question and APML in the long question as well. And they ask us all about management stuff. Like how would you explain prognosis to the patient? What investigations you would do, and what are the treatment options, follow-up, etc. So when they ask you about management, then management does not mean that you will start chemotherapy directly. You have to do breaking bad news first. If the patient is under some other team or in the ED, you have to admit under hematology, breaking bad news, explain the diagnosis, prognosis, and chemotherapy option for the patient. Because the patient may refuse to have chemotherapy, and or his performance status is not well and he is not fit for aggressive chemotherapy as well. So assessment of patient performance status, comorbidity, all these things that you do in your practical life in a hospital, you have to mention all of the things in bullet points. And yes, you have to urgently start the treatment if patient agrees, like careless prophylaxis, hydration. Um, if you are not planning any further biopsy, then steroid to reduce the uh, mass size, because if this is a big mass, it may be compressing the arteries, veins, or nerves. And then orthodox MRI VAC or ARDA EPOC uh, is alternative regimen. If they are not fit for both of them, then we have a less intensive, a bit hypersevered regimen. If they are not fit for that, then you can give more less intensive therapy. Or but this Burkitt lymphoma responds to chemotherapy very quickly. The mass usually reduces very quickly. So most of the people fail in the exam not because they don't know, but because they do not write the answer in a way they want. You may be knowing a lot, but if you do not uh, write them in a sequence that you usually do in your practical life, they will fail you. And you may have seen a lot of examples like that. So if they ask you how would you manage, you always start with admission if the patient is not admitted, with breaking bad news, leaflets, consent, uh, explanation of the disease, chemotherapy, radiotherapy if required. Radiotherapy is not usually used in Burkitt lymphoma, but for a general lymphoma case. And then this is emergency, but other patients who can wait, you discuss them in the MDT. And you know about the patient performance status and comorbidities as well. And then you plan the chemotherapy. And Okay, you have given the patient chemotherapy, but this patient has to be followed in the community as well. You make a discharge letter, inform the GP, give them a CNS contact number, and follow them up in the clinic as well. Then it completes your full management plan. If it is a 10 marks question in a long case, you will get 8 marks. If it is a Viva question, usually they give you hints, but sometimes they may not give you hints. They only want to listen to your complete answer. So if you miss some of the points, then they may deduct marks from you.
Okay, thank you.
Okay.